Our final panel of the day that will explore the value of primary care in communities, moderated by Dr. Tom Wroth. Thank you. You can go. I'll let you go sit there. Of Community Care of North Carolina, Bennett Graham of Main Street Health, and Dr. Ali Khan, Chief Medical Officer of Oak Street.
I think we're lucky, Bennett and Ali, because we got to listen all day to all these themes, and really, this is kind of the capstone panel, I think, for the whole day. And how much better could it be than to talk about the interaction between primary care and community? So it was kind of interesting. We had all the segments. We talked about the payer groups, Medicare, Medicaid, employer-based, talked about innovations overall, talked about the lifespan, but it all kind of rolls up into how we provide value to a community. And I think just thinking about the term community, the definition, there's lots of, it's a place, which is really key, but it's also multiple groups that have different shared experiences. And I think really look forward to talking to you both about your care models and how you approach going into a community and building trust and providing value and ultimately providing great care to patients. So just to kick off, I'll quickly introduce myself because I hope to jump in there into the conversation. We're, all states are unique. My name's Tom Wroth. I'm a family physician practicing in North Carolina, and I'm the CEO of CCNC, Community Care of North Carolina. And we've been in this conversation around primary care for multiple decades, 30 years. In our latest iteration, we manage a large CIN of independent practitioners, half pediatrics, half adult, half rural, half urban, and have about 600,000 Medicaid beneficiaries, 80,000 commercial Medicare. And that network was really built by community-based networks that back about 20 years ago, we set up 14 regional networks and had a coalition between practices, the hospital, public health, other community-based organizations, and kind of build up from there. So we've got a unique history, and now we're trying to learn from you all about how to move forward with value-based care from that foundation. So just to start, if both of you could just introduce yourselves and tell us about your organization, we'll start there and then we'll jump in. And Bennett, you want to go first?
Great. I'm Bennett Graham. I'm the president of Main Street Health. I started my career here in DC with the advisory board company, and then launched a palliative care company on the provider side called Aspire Health, and then ran across. And that was when Ali and I got together, and so we both worked together at a payer for a couple. I was there just for a couple years. Ali was there maybe a little bit longer, and but we both collaborated on sort of a provider model within a payer of trying to think about how to care for some of these highest risk, most underserved communities. And then we split off, and Ali went urban and I went rural. And so I now lead Main Street Health, which is a value-based care company exclusively focused on rural communities across the country.
Ben already introduced me, so I don't really need to do much more. Ali Khan, I'm a general internist in Chicago on the west side of Chicago. I had a really weird career practicing urban primary care in places as diverse as the Strip for Super Sick casino workers in Las Vegas with Rashika Fernandez-Pule and his first model with Iora Health. In one of the richest counties in the world, in the country, in Santa Clara County, seeing some of the most endemic poverty in San Jose and parts of the Bay Area, including even in Palo Alto, through the work that we ran as an integrated payer provider at CareMore Health. And then later on, a lot of the work that we did with Aspire and others in places like Memphis, Tennessee, Des Moines, Fort Worth, Texas, and the like. And then honestly, for where I started, like a few of the different people here, in terms of really wondering, as many people were running to global health lectures, trying to figure out what to do from an HIV/AIDS perspective abroad, that what we were doing for people who are housing insecure in Richmond, Virginia, right? So I think the challenges of the urban underserved have been kind of thematic across my entire career. I'm really lucky to be able to have almost exclusively practiced in value-based models since the start of my career. So not having been tainted from the scar tissue of fee-for-service. I serve as Chief Medical Officer at Oak Street Health. We are a national network of primary care centers for vulnerable seniors, Medicare enrollees, and duly eligible enrollees across 21 states, where we care for 225,000 folks today. A couple weeks ago, we got acquired by CVS. We'll talk about that later. But I think the intersection of sort of public value and like private investment has been a really interesting kind of thesis that I've been fortunate to see as Bennett throughout our entire careers. And so what that offers in terms of lessons of just, one, how do we really do the work of rebuilding trust and reducing the scar tissue for what that builds up within many communities? But second, how do we handle the two separate processes of like, one, the journey of making primary care not suck for folks and that to enter those careers, and then how do you actually make primary care joyful? And so a lot of interesting lessons along that way.
That's great. So really looking forward to this. And why don't we kind of jump off from there and maybe with both models, talk a little bit how Main Street and then Oak Street relate to the community, interact with the community, build trust with the community. How does that work when you go into a new community?
I can start. We're both on streets. Lots of Oak Streets and yeah, exactly. Oak Street and Main Street. So I think one of the things that we found when we were spending a lot of time in these rural communities was, life in a small town operates very differently than in metropolitan suburbia and sort of in an MSA, where it was not uncommon for me 2 weeks ago to cancel a physician appointment over my phone, or to cancel the reservation I had with my wife for a date night on Open Table or something like that. And sort of, I didn't think anything of it. In a small town, you don't do that because you're going to run into that doc at church on Sunday. And if you cancel that reservation 10 minutes before, that's someone's livelihood. There are only 6 spots in that restaurant. And so everything is so much more relational. And we even actually made some mistakes, even though we knew this going in the first year that we were getting up and running. We even tried to do some outreach from our sort of central hub in Nashville, and it was amazing how quickly patients realized that person on the phone was not in the office, where they would kind of say, well, how do I get there? Should I come in the back door or the front door? And what's the pie of the week? And it turns out like knowing the pie of the week actually matters in these communities as far as getting the trust of the patient. And so a lot of what has driven our design principle has really been this idea of developing deep, trusted relationships and really partnering with clinics. So we are not building and buying clinics. We felt like that was what was going to be most important, was to really buttress the existing primary care infrastructure, which is on very shaky ground in rural communities. And so we've found that really coming alongside and focusing with a more relational model that is still very much in-person care, patient-facing. We love telemedicine, we love data, we love technology. People in rural communities still want to talk face-to-face with a human. And so I think that a lot of that has driven a lot of our model.
I think probably a lot of common themes. I'll say, we've been in operation obviously about 10 years. And I think from day one, we've always said, what does it look like to co-design with patients? But we've learned along the way who else we have to co-design with as we've made a lot of mistakes in the journey of like getting to real trust in communities, right? So first off, right, like the communities that we serve, 100% of them are 300% or below FPL from a average income perspective. 99% of them are in health professional shortage areas. Name your desert, right? Like pharmacy, grocery store, primary care, so on and so forth. And of the 172 clinics that we have today, in almost all of them, the only other option for care is a federally qualified health center or teaching health center. By and large, academic medical centers are not there, even if they're across the highway, right? Multi-specialty groups, the large suburban practices, like these are places they don't cross, even in cities as large as Chicago or Philadelphia or Dallas, Fort Worth, right? So in that way, we've known from day one and through that kind of co-design that we are recreating built environments in places where they don't exist. So with each center adding 1,500 square feet in every center that are community spaces, not waiting rooms, but where they're heating centers when it's cold, they're cooling centers when it's hot, they're vaccination centers where for a lot of the pandemic in communities that were being hit hardest by COVID in both cases and deaths, but had no other infrastructure in which to do those kinds of events. They're also oftentimes the only sources of like reliable Wi-Fi. So computer access for housing insecure folks, sure, but really like a lot of our patients are not digitally naive. They just don't have broadband equity, right? So coming into our centers just to be able to pay bills, get on a video call with another physician, so on and so forth, log into that, wonderful app for a digital PT that somebody wants them to use, right? Like those things are happening over and over again, in addition to the programming to combat social isolation or teach diabetic cooking classes, so on and so forth. That was the first step, right? And for us, in like a very strong last mile focus, we thought of that in the same ways we think about like transporting people to and from appointments, or getting delivery of meds, or getting delivery of food, so on and so forth, or co-locating pharmacies. But I think what we've learned along the way is that the scar tissue that American medicine builds up from the medical industrial complex for people, especially the urban underserved, who have bounced back and forth with so many systems, not sure where to go or how to, that often falling through the cracks, requires that we actually have to do far more with who they trust. And so I think what we've learned, it's not enough. And each of our centers has about a staff of 6 to 8 community health workers and community engagement specialists who are running programming, who are building relationships with CBOs, so on and so forth. It's not enough to say, hey, like we've got a good relationship with these faith-based organizations, or we've got a decent relationship with these food pantries and we'll do some events. But to really say, like, to get the real concern, to the root of the problem, which is that people wonder, like, just like they did in my resident clinic as a trainee, how long will I be here, right? You have to build authentic bidirectional relationships with those organizations. And now over time, as we started to do, really think about how are we supporting them, right? In a full risk model where we're not billing for anything fee for service, we have the ability to say, is it right to give a PMPM payment to the local senior agency on aging, right? Or to the folks that we are using for housing access, right? Taking it beyond closed loop to really saying, how are we doing capacity building? So that's been the journey. We've made a lot of mistakes along that way. But when you want to if you're really focusing on trust, we think of it as our clinical model enables time and brings a lot of resources, right? As Dr. Kornitzer and others talked about in earlier today, we focus on follow through then to make sure we actually do the things that we need to do in shifting primary care from reactive to proactive, because we operate in communities, whether, Black, Hispanic, immigrant, smaller communities in Rust Belt cities, so on and so forth, that suffer that paucity of trust. So it is that continuum that gets you to trust over time, and then we have to keep it, and that's the hard part.
Ali, I think it's really fascinating talking about co-creating with the patient, their care plan, the what's going to help them reach their health goals. But at the community level, can you talk a little bit more about, if you were to come into a new community, how do you assess the assets of that community, the weaknesses, and where to start?
Yeah, so we this is again a place where we've learned a bunch and spent a bunch of time on this. We start with just mapping, right? I mean, obviously you can, as Bennett has done many times in his career, you can geomap the hell out of anything to understand sort of like income insecurity, to understand sort of hotspots of activity, to understand where you have resources that you can rely on. It takes a longer time. And we've built this playbook over time and really refined it in the pandemic of understanding who are the anchor community organizations, right? Who is the church in the Black communities that I serve on the west side of Chicago that are still functioning, still going strong, that are really seen as community outposts, right? What other faith-based organizations? Which hospitals are trusted and which aren't? Because that may be a very big difference. Whereas all the quality data I have in the world, or all the perceptions I have as a practicing physician about like, this place is great versus like, I would never send my parents here, and like who's willing to enter in risk deals with me and stuff like that, all of that can go out the window if the patient doesn't want to go, right? But you also have to spend a lot of time saying like, what is the fabric of, family service organizations, right? Who are the folks that are trusted when it comes to housing access? Like which shelters are trusted, which aren't, right? In that ecosystem over and over again, you identify, and like we spend a lot of time with our patient advisory boards and with each patient in the context of, 3 to 5 hours of intake of understanding who they trust. And then we have to basically like combine that data and then just go test it out, right? So we're constantly learning. We've learned to constantly learn and not just index on 3 or 4 relationships, because those can go kaput in 2 years, right? Especially as grant funding changes and the like. That is not easy work. And I wish that Unite Us or a different, NC360 and stuff like that, NC Cares could solve all that for us. It doesn't. We have to pair it with a ground game. And like, for us, omni-channel in that way becomes omni-channel engagement that's digital from things like Unite Us and telling us these things, analog from who we just discovered, and then shoe leather. How do you actually pound the pavement to learn and test?
That's great. And Bennett, you talked about building trust, contrasting with a rural community approach. Do you want to make any comments on how Main Street would do the same sorts of things in a rural community?
Yeah, I mean, I think that like even just from the very get-go, we realized that, I think I'm sure we'll get into sort of some of the shortage of physicians in rural here, but I think that even in spite of that, introducing sort of a brand new clinic in Obion County, Tennessee, was a losing ball game as far as sort of like, I think that as jealous as I am of Ali and the ability to like create this incredible care center and the experience that you have when you go in an Oak Street clinic is awesome. But I think that we realize that even in what looks nothing like an Oak Street clinic, that is like, I'm not sure that it's seen a mop in several years, and it's actually, I mean, it's incredible care. I mean, it is like world-class care that's being delivered in a lot of these rural primary care clinics that sort of, but I think that the ability to do that care between the visits and sort of develop that trust and sort of go a little bit deeper into the community. There's this interesting element that we observed amongst a lot of the rural physicians, that there's this kind of head and heart disconnect. And I think that there was some discussion in the previous panel about some of this, but just, a lot of the doctors that we work with, a sort of longitudinal whole person care is very much the ethos by which that they practice. Because that's what you do in a small town. Like, you go to the grocery store and you take care of half a dozen patients. But that's not how they're incentivized. They're incentivized on 15-minute medicine. And so I think that coming alongside that existing trusted relationship and then adding really that element of, well, what if we did actually start to ask some of these questions about what happens when the patient's going to leave this building? And it's not the prettiest building, but there's great care inside of these four walls. I think the literature says that patients retain about 40% of what a doctor tells them. Most doctors I talk to say that's a little high. I think that's real is like, when we go to our doctor's office and we sit on that white piece of paper in a backless gown, staring at in this sort of cold environment, it's nerve-wracking and it's really hard to remember all that stuff. And so when you do start to actually sort of run into these non-clinical barriers, you're hesitant to bring those up, especially in a small town. And I think that in addition to that, I've learned from Ali and every other physician that I've worked with, the sort of core principle of like, don't order it if you can't follow up on it. Yeah. And I think that what we've seen all too often is a little bit of a hesitancy from a lot of the physicians in some of these smaller communities to actually ask some of those questions that might be some of these non-clinical barriers. Because if I ask you about how are you going to get a ride to the specialist, or can you afford your drugs, et cetera, I don't really have a solution for it. And so that's where I think Main Street's been a real asset to our partners is, the core part of our model is we're embedding an additional staff person in that clinic as part of their team, who's really this non-clinical expert in how do I navigate someone through sort of from the moment the doctor is going to walk out of this room, how do I help you get to a healthier place by the time you come back. And I think that has sort of filled this gap that I think for our physician partners has been a real delight in sort of bringing back to that sort of joy of medicine, of realizing, because I think that, physicians hate when it's sort of like, hey, I told you to take your medicine, your A1C is still not moving, right? Of like, you're not changing your diet, you're not taking your meds, you're not doing these things. And I think that sense of sort of this like non-compliant patient is oftentimes probably not all that fair when we actually start to look inside of like what's actually happening to that patient. And so I think that that's been a place where giving physicians the resources and not just giving them kind of a recipe book and saying, hey, you got to go do this and here's the best practice, but not giving them the time or the resources, I think has kind of been an unfair ask of a lot of the physicians. And it is hard to navigate community resources that are unique in every single community.
Or like benefits that you have that you don't know how to access, right? Like, I mean, I think the trick, Dr. Christmas was talking about this earlier, right? Like our patients are, like physicians, well, we think we're alone, right? In a primary care setting. Our patients are often also, more often than not, they're worrying alone, right? And so they don't know who to rely on, who to trust. We don't know how to give them that time. And so like I think the common theme in what Ben and I are offering in different contexts is that ultimately, so who is walking with you, right? Who is helping you get to wherever you think you need to go and helping you when you stumble and then realizing, okay, maybe we need to go somewhere else, right? And that is what we all think we went into medicine for, right? But it's not what our system is built for by any means. So how we think about building in those capabilities, that's the road to trust, right? And whether that's at the individual level, whether that's in the CBO partnership level or something in between, that's, I think, the space where both of our organizations spend a lot of time.
And it sounds like for both of you that in between space is this broader primary care team, the navigator, community health worker, the care management process overall can be the link between the physician and community-based organization, can be the trusted person that they will talk about some of their social determinant of health issues. Can you both talk a little bit about, Ali, maybe starting with you, the care management model and how you approach that?
I mean, what I was going to respond to you with is that sometimes it's the driver, right? Like, I mean, for us, the biggest piece is that like in positioning a team to do proactive care, you actually have to give them time to do that, right? So a third of our team's time week to week for us is spent in and around proactive activities. Yeah, it's huddling at the start of the day to see who's in front of you, but it's really in and around bringing the whole team together. Physician, nurse practitioner, RN, social worker, promotor, CHW, sure, but driver, pharmacist, podiatrist, like MA, welcome coordinator, whoever, right? Because like those are the people who are hearing things in the waiting room, right? Those are the folks who are actually getting context when they're going back and forth. These are the people who know that there's actually, our behavioralists or social workers know they lost their job a few weeks ago, or if they're still working as a senior, or they're about to be evicted in 2 weeks. Like, how does that team come together to devise a single source of truth around like what's going on with this patient, what we should do, right? That could be clinical, that could not be clinical. Getting into that mindset requires getting a team that wants to operate at the top and the bottom of their license, right? If it's on some level, you're training everyone to think like a social worker. And like that is, I think a lot of us think we think that way and we actually don't, right? Like even the simple thing of like, I've handed out my cell phone number to every single patient I've had since my last year of residency. And like, it's never been abused. But like that piece of like, it's a question I ask every physician when I interview of like, how would you feel if we did this? No, we don't do that at Oak Street. It's not a policy. Where I worked previously at Caremore, we had 2 phones, so we did it all the time. But like it, like, and like, if I asked that in the context of trying to expand over 21 states, I'd have nobody to hire, right? So like getting folks at any level who are interested in doing that work, who are interested in depending on each other and learning not just to stick to their role, but to think outside of that and actually start to access creativity, that's the difference, right? So like care management becomes the clinical model and the clinical model becomes the care management model when it works really well. That was similar to what we did at Caremore and Aspire. It takes a lot of work to get there because we've all developed bad habits in fee-for-service.
I think for us, we actually had to kind of come at it from the opposite perspective from I think the experience from Caremore, Aspire, Oak Street, where you kind of got to design this clinical model and then sort of design the team and the space and everything around that. For us, we really sort of, as we were talking to a lot of the physicians that we were initially working with, we quickly realized that this term of practice transformation was not going to be very popular. I have yet to meet a country doc who wants to be transformed. But there was a willingness to be kind of nudged. And if it was easier, I think that, we heard from every physician that we were working with do not make me log into something else. Do not slow me down. I have to be at the ball field by 4:30. And like, don't change that. Cause that's actually, and honestly, like that's a really important part of their community engagement as the physician in that town. And so I think that making sure that we actually designed a sort of care model that actually sat underneath the culture and underneath the existing clinical workflows in that clinic was actually a core design philosophy for us, where a lot of what we're trying to do is say, hey, how do we tee this up for you, provider, so that it's actually easier for you? And, you already have the patient in front of you. Let's go ahead and can I log that, can we help you make sure that standing order for that mammogram gets signed right away? And can we give you sort of the task rabbit to go run and execute on whatever that next step is, the patient who's lonely, who needs a phone call next week. And there's nobody really in the office to do that except for who, right? And so I think that making sure that we actually sort of sit underneath that existing workflow, but it was kind of hard to do because it was such a different design philosophy. But I think that we found that was actually sort of, and I think that what's been interesting is as we have more and more tenured clinic partners, the kinds of questions that our physicians are now asking, once they hit that sort of 6, 12, 18, 24 month partnership, it is the sort of 200 level kinds of questions. I don't know that we're sort of yet at the sort of Oak Street level, sort of 400 level, master's level, sort of conversations. But I think that they are, I think we are sort of having a lot of those really interesting questions from a lot of our providers of sort of, hey, what is that next step in regard to really caring for this patient for the next decade as opposed to sort of the next 10 minutes?
Well, today one of our major themes has been value-based care, and both of you work with value-based care as a construct for the care model for seniors. But can you sort of look at this through the lens of the community and providing value to the community? And what has value-based care enabled you to do around health equity, around improving health outcomes and interacting with the community?
I mean, for us, this is pretty simple, right? Like, one, where we go, like by nature of who we choose to serve, right? Like what value-based care enables is an investment in and redistribution of primary care supply into places that are just ignored, right? Like we have not invested in communities of color. We have followed structural marginalization from a redlining perspective in communities all across the country. And so like whether we're doing that in Jackson, Mississippi and Mobile, Alabama, or whether we're doing that in Albuquerque and Colorado Springs, right? It's the same patterns over and over again. So first, like how we think about, we already have a primary care shortage in this country. And then when we think about maldistribution, where we see heavier concentrations in rich parts of cities and wealthy suburbs, like where I grew up right across the river in Fairfax County, like that is different. And it's important work to activate those practices. But when we are doing this in rural Tennessee or in, rural Mississippi or in, East Texas, right? Like it is different work and it doesn't have the same resource profile. It requires a much larger investment. And we already know that the 3 to 5 cents on the dollar in American healthcare that we spend on primary care is insufficient. So for us, what value-based care enables is when you think about that in a 5x or 10x sort of profile, you think about all the things that we build in, right? What the last panel just discussed in terms of who's on the team and how do we think about that across the lifespan. That's a real investment, right? Like in commercial insurance, like we think about a $30 to $40 per person per month investment in primary care is high. We're thinking about models, whether from the Aspire perspective and CareMore previously or at Oak Street or even at Main Street, in the $100 to $200 range plus, right? That is a dramatic shift of investment to primary care. And we're human capital innovations, right? You guys always have great call centers, but like it's not the technology, right? It's not some magical thing in the cloud. It's not generative AI. It is blood, sweat, and tears of people working on the ground. And it is like a mix of brick and mortar or it's virtually enabled, but it's about like standing with people and density of interactions. That is the core that gets the kinds of phone calls that Dr. Christmas gets from her patients, right? That doesn't happen by accident. And we don't see many accidents in traditional primary care in this country anymore, right? For exactly this reason. That's what it takes. Like, you have to put your money where your mouth is. And what we see, whether it's in managed Medicaid, Medicare Advantage, or an ACO REACH, is actual work towards that, making progress of getting back to that real density of interactions.
And I think for us, I think all of those things, and I think we were just seeing such a low penetration of value-based care in rural, and sort of like, but in so many ways, sort of why, right? Because actually these doctors actually are really, really attuned to that style of medicine, and actually could benefit from these resources that much more. And so I think that as far as taking that, I mean, like somebody was referencing sort of the sort of doctor on a horse model of medicine, right? And that is actually sort of very much sort of the spirit of a lot of these community-based physicians who want to be able to practice that way.
Dr. Quinn.
Yeah, exactly. And so I think that there is, I think we do want to have that joy of medicine in these practices. And I think that in particular, I think in a lot of the rural communities we're seeing is the burnout is really extremely real. And the retirement challenge of just, I think a lot of the rural physicians, there were a number of our clinics who were going to close their doors in December and just kind of say, hey, this is just too much. And so I think having kind of time and money were the two things that they didn't have as far as the key pieces to be able to sort of make that switch. But the ability to actually participate in a lot of the, what are great programs that, whether it's things that CMS is doing or that commercial plans or Medicare Advantage plans, those still take serious capital investments to be able to just step into the room. You're sort of just to open an MSSP ACO, it's $50,000 of escrow, right? Just to sort of like put money in sort of aside. And so I think just the hurdles, I think, were pretty real. And so I think being able to do that in a way that allows more participation across, the majority of the communities we're in are 2,000 to 5,000 population. So it's, these are really small communities who really can benefit from these resources, but just historically had not had a lot of access.
But I think to that point, right, it requires a bunch of intentionality, right? When we offer big things for everyone, MSSP is a good example. We concentrate dollars outside of the physician-led ACOs in large systems, and like care continues as usual, right? We move the needle potentially in savings in certain models. We might get better quality to a certain extent, but like we don't hit maldistribution. Like groups like Main Street have to be intentional about saying, we will specifically go after rural. We are not going to go do this in Asheville, right? Mm-hmm. We are going to go do this in like the corners of North Carolina that nobody is going to, right? Groups like us have to say, we are going to Flint. We are going to Burton. We are not going to Ann Arbor, right? Like, and there's a reason for that. And obviously, like, whether we take a density specific model, these guys don't have to as much. But the point being that we cannot be all things to all people, and especially where by design, particularly for the American Academy of Family Physicians, we aim to be all things to all people, right? And so shifting that mindset to say like specification is actually okay when we are trying to advance equity and trying to like really move the needle on outcomes, that's a big part of that journey.
I know, just shifting topics a little bit, that workforce, Bennett obviously has kind of alluded to the issue of workforce in rural areas, not enough residents getting trained in community-based settings in rural areas. And Ali, for you, with the city block model, tell us about workforce and what sort of challenges you've had and how you all approach that.
Yeah, no, I think it's interesting because I think there's like a few pieces, right? I think for both of our organizations, like learning from organizations like City Block, where like the community health worker, the promotora model, like obviously enables extension in a way of that locus of trust, is really useful. At the end of the day, though, we still need people who have to like sign orders, right? And like give care and to diagnose. Obviously, we aim for a one-to-one model in terms of physicians versus advanced practice providers in terms of our ideal workforce. But the nature of primary care supply right now can make that very challenging, right? So like I think the same work that Bennett is doing to try to uplift physicians in existing communities, we're doing the same. We're also realizing we have to train our own, right? So we do a lot of work on the undergraduate medical education level and GME level on the physician side to sort of, again, expose people to pathways in which primary care can be a sustainable career and potentially even potentially joyful, right? But really, we've also said, we've partnered with the University of Michigan School of Nursing to say, we have to train nurse practitioners in a residency-based model to like prepare them for the complexity of team-based primary care for very medically complex patients who have also a lot of sociodemographic pathology, right? So we are now training 50 NP fellows a year across the country for 2 years with us, training them in obviously a bunch of clinical medicine, but also the work of like team-based care, value-based care, and like team leadership and interprofessional model. We intend to grow that to 150 a year because that's what we need. I mean, to really make this work. And it's not because we have any desire for cost savings or substitution. It's that we have to deal with the reality of the primary care workforce. We're doing the same thing in terms of trying to grow our own medical directors, like in a partnership with Kellogg and Northwestern University, get an MBA, we'll do whatever we have to try to make primary care attractive to physicians as well. But like when the upstream issues of people sorting out of primary care are so significant at the undergraduate medical education level, even beforehand, from a hidden curriculum standpoint, we've realized we just have to partner with a bunch of people to try to impact that at all levels and deal with reality. Because if we are going to deliver the kind of care we would want for our parents or grandparents, there's a basic level of clinical heterogeneity that we have to try to control. We always want positive clinical heterogeneity at the top level, but like 90% of physicians and nurse NPs think that they're above average. The reality is not true of that. So like we have to figure out how we're controlling for negative heterogeneity, and training is the answer.
That's great. Great answer. And I know our time has gone really fast. Our conversation has been wonderful, but I do have one walk-on question for both of you. And just thinking about the future of primary care and looking at both your organizations over the next year, what are the bright spots that you're looking towards over the next year or so?
I would say over the next year, I mean, it is, I think I'm one of probably the few people in the country who's gotten to see as much of the middle of America over the last 3 years, where I spend most of my days not in a suit and tie, but in like, jeans and a Carhartt.
I don't think I've ever seen you in a tie, to be fair.
And it is, I just would say it's like, it is actually just really encouraging to get to see the kind of care that's being provided in these communities. I mean, it really is pretty special to watch the kind of primary care that's performed in a lot of small towns in America, where they're doing everything. I mean, like these are sort of multi-specialists in one. And it is really inspirational to get to watch and get to see that happening. And so I think just getting to, I've been so encouraged over the last year. I think I'm looking forward to the next year of just getting to see more of that. And also I think getting to tell more of that story. I think that it's been particularly exciting, I think, to get to see a lot of the payers start to pay more attention to some of the equity issues that exist that are sort of rural urban equity issues of sort of, there has been sort of this, when you look at some of the HEDIS questions and you realize like, hey, like there's actually some bias in some of these questions around access to care that like, of course they don't have access to care to some of these specialties in some of these particular communities. And so I think that the attention and sort of the excitement and the innovation that's happening in rural America is very real. And there's a lot of good innovation that's happening in the primary care space in particular.
I'd say two quick things. One, I think like at least on our side of the fence, we're hitting a place where like everything isn't proprietary anymore, right? So like if we're in Dayton, Ohio and Agilon's in Dayton, Ohio, we should figure out how to partner, right? Like figure out how to find the right specialist is not like intellectual property, and we go forward. But second, I think we're starting to see on the payer side, especially led by CMS, real investments in putting their money where their mouth is on equity, right? With an ACO REACH, the sort of additional benchmark adjustment for folks who are living in most vulnerable areas, most structurally marginalized areas, putting that money there and actually taking money somewhat out of places that aren't as structurally marginalized will actually drive supply, right? We aren't going to get anything else in terms of addressing disparities until we put money into rural and densely urban communities. And it's models like these where we actually start to see that momentum happening that to me seem like the most exciting.
Well, thank you both so much. Wonderful conversation. And I think that's the end of our time. Let's give them a round of applause.